Good afternoon, ladies and gentlemen. In the second talk, I wanted to describe the University of Pittsburgh Medical Center experience with robotic assisted neck dissections. I would like to thank Dr. Koh for his mentorship and his guidance in allowing us to start our program in robotic neck surgery at the University of Pittsburgh. As we all know, neck dissections and lymphadenectomies are routinely employed both for the removal of occult and known local regional metastasis from head and neck cancer. Trends have led from maximally morbid to minimally invasive procedures as literature supports equal but better outcomes. We're all familiar with the radical neck dissection, which often is deforming and functionally as well as cosmetically for these patients due to resection of the critical neurovascular structures. More recently, the selective neck dissection has gained increasing popularity, and this is usually performed by using a hockey stick incision. And I have borrowed this picture from Dr. Eugene Myers' textbook. And here's a picture of a young lady who has undergone a selective neck dissection and is recovering from that. And nonetheless, these major surgical procedures or surgical scars lead to cosmetic deformities in these patients. The lateral neck dissection via facelift incision, of course, was initially described in Korea for metastatic thyroid carcinoma. This has been performed through a transaxillary incision. More recently, this technique has been modified to accommodate the modified facelift incision to allow for selective dissection of only the lymph nodes of the neck when the thyroidectomy or the thyroid bed or the central neck does not need to be accessed at the same surgical setting. With the help of Dr. Koh, we've undertaken extensive cadaveric dissections to first familiarize ourselves with the anatomy of this area and to describe for ourselves the ability to perform these robotic-assisted nodal dissections in the North American patient population. Clearly, we're limited somewhat in North America because our patients tend to have a larger body mass index. And so some of the methodologies that may be applicable to patients with smaller body mass index and favorable anatomy may be a bit more challenging in the North American population. So we sought to determine whether or not this surgical technique would be accessible and useful for patients with such a disease process. We performed 6 robotic-assisted neck dissection procedures with IRB approval and informed consent. 4 procedures were encompassed dissection of levels 2 through 4, 1 encompassed dissection levels 2 and 3, and 1 was for oral cavity cancer encompassing dissection levels 1 through 3. We then sought to undertake a retrospective comparison by matching the 3 level 2 through 4 nodal dissections that were performed with 6 consecutive open 2 through 4 ipsilateral unilateral neck dissections at our institution. We noted the operative time, estimated blood loss, wound drainage, number of lymph nodes removed, as well as hospital stay for these patients. In performing this matched comparison, what we found was that the operative time was the only significantly different variable in these 2 groups. It took about twice as long, roughly, for us to perform the robotic-assisted nodal dissection as compared to the open neck dissection, although this length of operative time is clearly related to the small group of patients that were studied. The estimated blood loss was comparable between groups, although there was a tendency to have increased blood loss in the robotic neck dissection group. The number of lymph nodes were not significantly different in terms of the retrieval rate. However, there was a trend towards a slightly better nodal clearance in the robotic-assisted neck dissection group, and the total drainage in terms of output from the gastric tract drains that we used after surgery was comparable between these 2 groups. The length of stay was also comparable for all the patients. We suspect, therefore, we posited, therefore, based on this, these findings, initial findings, that the robotic neck dissection offers comparable nodal clearance rate to open neck surgery for this group of patients. We'll show here a brief video of the robotic neck dissection, which I will ask my colleagues to play. Can you pause it?